Half of all deaths in developed countries trace back to one thing, and it's not cancer, not accidents, not infections. It's your blood vessels. Roughly 1 in every 2 people on this planet will eventually die from something connected to the heart or the arteries. And here's the part that doesn't get enough attention. The plaques that cause heart attacks and strokes don't show up overnight. They've been growing quietly inside your arteries for 20, sometimes 30 years before you feel a single symptom. You go to work, you eat dinner, you sleep, you wake up, and inside, the process keeps moving forward without telling you anything. But there's good news, and that's why this video exists. Almost every single factor that speeds this process up is something you can influence yourself. No IVs, no miracle pills, no $5,000 treatments. What you need is to understand what's actually hammering your vessels day after day. Some of it is obvious. Some of it almost never comes up in a 15-minute appointment. And one of the biggest factors, the one we'll get to in a minute, surprised even cardiologists when newer research started lining up the numbers. If clear, honest health information matters to you, hit subscribe and leave a like. That's what helps this channel grow. The goal here on Dr. Waterling is 300,000 thinking, curious viewers, and you're part of getting us there. Checklists and short health posts go out on my Telegram channel, and the QR code is on your screen right now. So when does it actually make sense to start taking your vessels seriously? The rough line in the sand is age 40. Not because something breaks on your 40th birthday. It's because somewhere around that age, the hormonal background you've been running on starts to shift. The sex hormones that quietly protect your arterial walls when you're younger begin to decline. For women, this is especially noticeable approaching menopause and after it. Estrogens act as a kind of natural shield for the inner lining of your blood vessels. And as long as estrogen levels stay high, heart attacks in women are genuinely rare. For men, the curve is gentler, but testosterone slowly drifts down too. Before 40, your body forgives a lot. You can eat at strange hours, sleep 5 hours a night, skip the gym, and your vessels mostly hold up. After 40, that grace period ends. The 20 or 30 years of small daily damage start to add up, and the plaques that were sitting there quietly grow to the size where they actually start to interfere with blood flow. This is the age where a more attentive checkup starts to make real sense. A blood panel that includes a full lipid profile, fasting glucose or hemoglobin A1C, blood pressure tracked over time, and depending on your risk picture, sometimes an ultrasound of the carotid arteries in your neck. Which specific tests you need is a conversation worth having with your primary care doctor or a cardiologist, because the right panel depends on your personal history. But that doesn't mean people in their 20s and 30s get to coast. Whatever you build into your habits at 25 shows up at 45. So a basic annual blood test and a blood pressure reading once a year is reasonable at any age. It's the cheapest insurance policy you'll ever buy. So what actually speeds up plaque growth? The first factor has been studied for the last 7 decades, and there isn't much room for debate: smoking. There's nothing philosophical to say here. Smoking kills, and not just your lungs. Nicotine and the dozens of combustion byproducts in cigarette smoke damage the inner lining of your blood vessels, a layer called the endothelium. The endothelium is 1 cell thick, and in a healthy person, it should be smooth, almost like the inside of a glass tube. And it's not a passive lining, it's an active organ. It controls how wide or narrow your arteries get from minute to minute. It releases signals that prevent unnecessary clotting, and it regulates how blood pressure responds to activity. When the endothelium gets damaged, all of that starts to misfire. Where the surface gets roughed up, cholesterol particles begin to slip in, specifically the kind labeled LDL, the low-density lipoprotein you've heard called bad cholesterol. Your immune system spots these deposits, treats them as foreign material, and sends in macrophages, the cleanup cells designed to eat debris. The macrophages absorb the cholesterol and turn into something called foam cells. The foam cells pile up, a fatty core forms. A thin cap of connective tissue grows over the top. And there, in plain biology, is your atherosclerotic plaque. Step by step, year by year. With smoking, this damage runs continuously. Every cigarette is another wave of micro-injuries to the endothelium. Nicotine narrows your arteries and bumps up blood pressure on top of that. Carbon monoxide reduces how much oxygen your blood can carry. And smoking also makes your blood thicker and stickier, which means clots form more easily on top of any plaque that's already there. It hits you from 4 directions at once. And that's before we even mention lung cancer, throat cancer, chronic bronchitis, or emphysema. If you smoke, quitting is the single highest yield conversation you can have with your doctor. The data here is striking. The benefit to your vessels starts showing up within months. And within a few years, your cardiovascular risk drops close to that of someone who never smoked. The body has a remarkable ability to heal once you stop hitting it. The second major factor is diabetes. The short version, when blood sugar runs high for long stretches, your blood basically turns into syrup. Excess glucose sticks to proteins in your vessel walls in a process called glycation. Picture a hard candy dropped into a glass of water. Slowly, it makes the water sticky and thick. Something similar happens inside your arteries when sugar runs high day after day. The walls lose their elasticity, the endothelium gets damaged, and from there, it's the same plaque-forming sequence I just described. But diabetes does something else, and this is where it gets ugly. It doesn't just damage the big arteries, it also chews up the tiny ones. That's called microangiopathy, damage to the smallest blood vessels in the body. It's why people with long-standing diabetes can end up with kidney failure. The clinical name for that is diabetic nephropathy, and it's one of the leading reasons people need dialysis. The same kind of damage hits the back of the eye, which is diabetic retinopathy, and it can progress to blindness. It interferes with how wounds heal, especially on the feet. That's the diabetic foot, and in advanced cases, it can lead to amputation. And on the large vessels, diabetes drives the same heart attacks, strokes, and peripheral artery disease everyone else gets, just faster, and at younger ages. In other words, diabetes is a slow demolition of your entire vascular system all at once. The hardest part is that type 2 diabetes can develop for years without obvious symptoms. The stage before it, pre-diabetes, where your sugar isn't quite normal but doesn't yet hit the diabetes threshold, can last a decade. The whole time, your vessels are already taking damage. So if you know your fasting glucose has been creeping up, or someone has mentioned the word pre-diabetes to you, that's a conversation to bring to an endocrinologist seriously, not casually. And a simple annual hemoglobin A1C test, a single blood draw that reflects your average sugar over the past 3 months, is a reasonable thing to ask about once you're past 40, especially if you carry extra weight or have diabetes in your family. And now the third factor, blood pressure. This is where the story gets interesting. For decades, cardiology treated smoking, diabetes, and high blood pressure as roughly equal players in driving atherosclerosis. They were all bad. They were all weighted about the same. But large pooled analyses over the last several years, looking at tens of thousands of people, have shifted the picture. When you compare these factors head to head in well-controlled data, sustained high blood pressure, what doctors call arterial hypertension, comes out as the single most damaging force on the vessel wall. It pulled ahead of both smoking and diabetes. That's a meaningful shift because blood pressure is the factor people are most likely to shrug off. There are millions of people walking around with readings of 150 over 90, 160 over 100, telling themselves, that's just my normal, doing nothing and quietly damaging their arteries every single day. The mechanism is actually pretty intuitive. Picture a regular garden hose with water moving through it. If you cranked the pressure up well above normal and held it there for years, the hose wouldn't burst right away. If the hose were living tissue, it would adapt. It would thicken its walls, reinforce itself, get stiffer. That's a protective response. The cost of that protection, though, is that the hose loses its flexibility. The same thing happens with your arteries under chronic high pressure. They lose the ability to smoothly transmit the pulse wave that comes from each heartbeat. They don't expand properly during exercise. They get brittle. And a stiff, damaged wall is exactly the kind of surface where plaques form most easily. So high blood pressure isn't a separate condition sitting next to atherosclerosis. It's basically a direct on-ramp into it. On top of that, high pressure makes existing plaques more dangerous. A strong pulse of blood can shear the cap off a plaque, a clot forms on the spot, and the result is either a heart attack or a stroke, depending on where it happens. So if your reading is consistently above 140/90, that is not just your normal. It's not an age thing. It's a real conversation to have with your doctor. The modern treatment of high blood pressure is one of the genuine success stories of cardiology. There are several different classes of medication that work through different mechanisms. Doses can be tuned, side effects can usually be managed, and the right combination for you can almost always be found. And when blood pressure is brought down to target, the drop in heart attack and stroke risk is measurable and substantial. This is one of the most rewarding interventions in modern medicine. The right pill, taken consistently, genuinely extends life. One more important point on this. How you measure blood pressure matters. A single reading at the doctor's office isn't a real picture. Being in a clinic alone raises plenty of people's numbers, a phenomenon known as white coat hypertension. The most informative reading is taken in the morning, after you've woken up, before you eat anything, and before you take any morning medication. Then in the evening too. Twice a day, for a week, in a quiet room at home. That's the kind of data your doctor can actually work with. A home blood pressure cuff isn't a luxury item anymore. It's a basic tool for anyone with suspected hypertension or anyone approaching their 40s. Moving on, the fourth factor is excess weight. And here we run into two big problems at once. First, adipose tissue, body fat, isn't just stored energy. It works as a real endocrine organ. It actively converts hormones from one form to another in a process called aromatization. In men carrying significant abdominal fat, a portion of their testosterone gets converted into estrogens. That's part of why men with very large bellies often show characteristic changes: widening hips, breast tissue development, dropping libido. In women, the same machinery throws off the delicate balance between different hormone groups. The whole endocrine system starts running off key. On top of that, fat tissue secretes dozens of signaling molecules called adipokines that influence inflammation, insulin sensitivity, and appetite. Endocrinology research has shown this for years. So excess fat isn't passive cargo you carry around. It's an active participant, constantly interfering with how your body runs. The second problem is mechanical. Extra pounds are a direct workload increase on your heart. Take a simple example. A person about 5 feet 7 inches tall would normally weigh somewhere in the range of 145 to 155 pounds. In real life, plenty of people carry 300, 400, even 450 pounds or more. The heart in that situation has to pump blood for not one body, but for what amounts to 2, sometimes 3. That's a massive chronic overload, and the heart never gets a day off. 24 hours a day, 7 days a week, year after year, decade after decade, it's running at double the workload. There's a well-documented pattern in cardiology where people with severe, long-standing obesity develop what's essentially a stretched-out heart. The chamber walls thin out, and the muscle dilates to the point that it can no longer squeeze effectively. The clinical name is dilated cardiomyopathy. The heart turns into a stretched bag instead of a strong pump, and in some of these cases, the patient didn't have diabetes or even particularly high blood pressure. The weight alone was enough to wear the muscle down. And on top of all that, fat tissue keeps a low-grade inflammation running in the background, which connects directly to the next factor we're about to talk about. One more thing on weight. The most dangerous kind is visceral fat, the fat that wraps around your internal organs deep inside the abdomen rather than sitting just under the skin. That's the classic firm beer belly. Visceral fat is biologically far more active than subcutaneous fat. It pumps out more inflammatory signals, it does more damage to insulin sensitivity, and it has a stronger link to cardiovascular events. This is why waist measurement matters as much as the number on the scale. For men in the US, a waist circumference over about 40 inches is considered a risk threshold by major guidelines. For women, the line sits around 35 inches. You don't need a single blood test to take this measurement. A tape measure around the belly button, standing up, exhaling normally, and you've got a useful piece of information about your own cardiovascular risk. The fifth factor is chronic inflammation. And there's a connection here that gets discussed in cardiology journals, but almost never makes it into a regular checkup conversation. The condition of your teeth and gums is directly linked to the health of your blood vessels. Any untreated cavity, any chronic gum disease, any low-grade dental infection is a constant source of bacterial inflammation in your mouth. Bacteria and their breakdown products leak into your bloodstream every time you chew, brush, or even eat. Your immune system reacts. Systemic inflammation runs at an elevated level for years on end. And here's the key part. An atherosclerotic plaque is basically an inflammatory structure. Chronic background inflammation makes plaques unstable. That distinction matters more than people realize. A stable plaque can sit in an artery for decades without causing a catastrophe. It has a thick, fibrous cap, blood flows past it, and the person may go their whole life without knowing it's there. An unstable plaque is different. The cap is thin, the inside is actively inflamed, and at any moment it can rupture. When it does, a clot forms on the broken surface, the artery closes off, and you get either a heart attack or a stroke. Most major cardiac events happen this way. Not because a plaque gradually narrowed the vessel until no blood could pass, but because a plaque suddenly tore open. So regular dental care, keeping cavities filled, getting a professional cleaning twice a year, treating gum disease properly isn't cosmetic. It's part of cardiovascular prevention. The same goes for chronic sinus infections, chronic tonsil inflammation, any smoldering infectious focus anywhere in your body. A chronic tonsillitis that no one has ever properly addressed sends a steady stream of streptococcal antigens into the blood for years. A chronic gallbladder inflammation, a chronic prostate issue, a chronic gynecological inflammation, they all feed into the same pool. If something has been quietly bothering you for years without resolution, that's worth bringing up with your doctor and working through one source at a time. It genuinely changes the inflammatory tone of your whole body. There's a pattern that shows up in primary care that looks something like this. Take a case from the literature. A man, call him James, 58, no diabetes, blood pressure mildly elevated but managed. He had untreated periodontitis for the better part of 2 decades because dentist visits were always something to put off until next month. After his first stint, his cardiology team coordinated with the periodontist. Within about a year of clearing the gum infections, his inflammatory markers dropped meaningfully. It's not magic and it's not a cure for atherosclerosis, but it's exactly the kind of overlooked piece that ends up being part of the bigger picture. The 6th factor is stress and your overall psychological state. And this might be the most underrated piece of the whole puzzle. When you tell people stress damages their vessels, they nod politely, sure, but it usually doesn't land as something concrete. It should. The link between mental state and vascular disease is direct, and the biology is clear. Chronic stress means chronically elevated cortisol. It means your sympathetic nervous system, your fight or flight wiring, is running hot all the time. That means higher blood pressure, higher blood sugar, disrupted sleep, and often emotional eating as a coping strategy. In other words, chronic stress quietly assembles several of the factors we've already talked about into one package. Pressure goes up, weight goes up, inflammation goes up, vessels take the hit. Stress isn't just nerves. It's a specific physiological cascade with specific consequences. Acute stress matters too. Cardiology has clearly documented cases where a sudden emotional shock, grief, terror, a devastating piece of news triggered a heart attack or a heart attack-like event in someone considered relatively healthy. There's even a specific syndrome with its own name, Takotsubo cardiomyopathy, sometimes called broken heart syndrome. After a major emotional blow, the left ventricle of the heart temporarily loses its ability to contract normally. It's rare, but it's a perfect demonstration of just how directly your emotions and your heart muscle are wired together. And then there are the slow emotional patterns people carry for years without even noticing. Unresolved resentment, long-running family conflict, the constant sense of being in the wrong job, the wrong relationship, the wrong life. That stuff works like a low background hum that wears the body down over decades. The link between chronic depression, persistent anxiety, and cardiovascular events is well established in medical literature, not a soft psychological claim. People who live in long-term depression have a measurably higher risk of heart attack than emotionally stable peers of the same age. This shows up consistently in large cohort studies going back decades. A lot of this background tension traces back to early life, often to relationships with parents. And this isn't about assigning blame. Our parents worked with what they had, with the tools and knowledge available to them in their time. Most people only really start to understand this when they become parents themselves. And that understanding often shifts something internally. People who carried resentment toward a mother or father for years sometimes find, after raising their own children for a while, that they're looking at their parents through a completely different lens, and something quietly lets go. There's a technique that comes up often in psychotherapy: writing a letter to a parent. You don't have to send it. You don't have to show it to anyone. You write down everything that was never said: the hurt, the misunderstandings, the resentment. And then you finish it from a place of gratitude. Gratitude for life itself, regardless of what came after. Even if a parent has passed away, this kind of letter still has psychological value. Many people report that something heavy lifts after going through this process. It's not a treatment for atherosclerosis, obviously. No letter will dissolve a plaque that's already there, but it's one of those tools that can lower the chronic emotional stress load. And once that load comes down, the load on your blood vessels follows. If this resonates with anything you're carrying, working through it with a licensed therapist is often more useful than another round of blood work. The same principle applies to long-running unhealthy relationships, jobs that drain you for decades, or a constant internal hostility toward yourself. All of it acts as slow poison on the vascular system. And sometimes, sitting down with a therapist or a counselor does more for your cardiovascular health than 10 more lab panels and 5 different specialists ever will. If you sense something is off in this dimension, it's a real conversation to have with your doctor. Here's a question for you while we're on this section. After 40, the rate at which plaques can develop genuinely speeds up. Hormonal protection drops, and every single risk factor we just talked about hits harder. So drop your age in the comments. I'm curious how this audience splits across decades, and at what age people in different places first start taking vessel health seriously, because it changes how I shape future videos. If you pull everything together into one picture, the condition of your blood vessels is, to a very large degree, in your hands. Blood pressure control is the top priority, the first thing to know and the first thing to manage. After that, in order of impact, quitting smoking if you smoke, keeping blood sugar in check, getting your weight into a reasonable range, addressing chronic inflammatory hotspots like your gums and any low-grade infections, and taking your psychological state seriously. None of this is exotic. None of it requires a private clinic or a 5-figure protocol. It's basic attention to yourself combined with regular foundational screening through your doctor. Once a year, a complete blood count, a basic metabolic panel with a lipid profile, fasting glucose or hemoglobin A1C, blood pressure tracked over a couple of weeks, and a dental checkup. That's the floor, and it's within reach for nearly everyone. From there, depending on what shows up, your doctor may add a carotid ultrasound, a stress test, or a referral to a cardiologist or an endocrinologist. The specifics are always individual. Take what's useful here, but run it by someone who knows your full medical history before you make any actual changes. That conversation is where the real plan gets built. If this gave you something practical to think about, hit subscribe and leave a like. That's what helps clear health information reach more people. 300,000 subscribers is where we're headed on Dr. Waterling, and you're part of that. Grab the checklists on my Telegram channel, and the QR code is on your screen right now.